Welcome to the Race, Health, and Happiness podcast, Season 2, Game Changers. In this episode, I interview my girl and colleague, Dr. Marcia Anderson, Indigenous woman, mother, physician, advocate, scholar, FEMME, and just pure FIYA. We dive into the impacts of colonization and her own personal experiences of anti-Indigenous racism in healthcare. Although this was recorded before the tragic unearthing of Indigenous children's remains in Kamloops BC, the approaches that she talks about to healing and the way she describes it here can be applied to overcoming almost any form of racial trauma. So I hope it's helpful to everyone directly and indirectly affected by this act of structural violence. And stay tuned. We have another bonus episode together on radical self-care. So buckle up. Here we go.
Warning. This episode contains frank discussions of race and racism that some may find challenging to listen to. Listener discretion is advised. But it also contains stories of overcoming challenges that some may find to be inspiring. Enjoy.
The Race, Health, and Happiness podcast is hosted by Dr.Onye, certified public health physician specialist and family doctor. The views expressed by Dr. O's guests are their own and do not necessarily represent her opinions or those of the podcast. Check out the show notes for more details. And now, here's Dr. O.
Hi, my name is Dr. O, and welcome to my podcast, Race, Health, and Happiness. We live in a world where Black, Indigenous, and people of color are more and more aware of the blatant and subtle ways that systemic racism impacts our lives. And as a doctor, I'm interested in how that affects people's health. This podcast is about how to stay healthy and happy despite all that noise. My guest today is Dr. Marcia Anderson. She is a Cree Anishinaabe physician who practices public health and internal medicine. She is a cisgender femme. She completed her medical training at University of Manitoba and a master's in public health from Johns Hopkins University in the United States. She is a medical officer of health for the Winnipeg Regional Health Authority and a past president of the Indigenous Physicians Association of Canada. Since 2017, she has served as the executive director of Indigenous Academic Affairs of the Ongoma Indigenous Institute of Health and Healing. She is also currently the Vice Dean of Indigenous Health for the Rady Faculty of Health Sciences. Dr. Anderson, I'm so glad to see you there out in Manitoba. I wish we could have been in the same room, but this is the next best thing. Welcome to Race, Health, and Happiness.
Thank you, Dr. O.
Dr. Anderson, I cannot wait to get into all of the different aspects of your work and your dedication to equity and issues of race and racism. But for every guest I have on this show, I always like to start with this one question. What is your superpower?
I do love that question. And where I would go with it for this particular context is I think my superpower is when these terrible situations come up, experiences of significant racism, really tough challenges in the academic environment, in the healthcare environment, that I don't get stuck in despair. That where my mind goes is what are the structures that need to be changed and can be changed? What's a path forward? What's a solution? And that, yeah, I don't get stuck in it. I have my feelings around it. I need to handle those feelings, but I am able to find and see a path forward.
We're going to dive into some of that and some of these challenging moments. But first, I think it's important for us to kind of ground ourselves. And I want to give space for you to kind of describe your work and yourself. But I do want to say that, we are blessed that Race, Health, and Happiness has an international audience. So, I was hoping you could break down for our listeners what it means to be a Cree Anishinaabe woman in Canada.
Wow, that's kind of a big question. Um, One thing I suppose, even within Canada, I would like people to know is that I live, work, and play on Treaty 1 territory, and that this is the territory of my ancestors. And so, on more than one occasion, I've sat out on my deck looking out across the field and to the sunset and thought about how my ancestors also have sat in these places and in this environment. And it really gives me an important longitudinal view when I think about, things that my grandmother experienced as an Anishinaabe woman who moved to the city in 1954, the year my dad was born, was told she couldn't be a nurse, to the work that I am able to do 2 generations later, and what that means in the kind of lineage, looking forward to my daughters as well. And so I think to me, being a Cree Anishinaabe woman doing this work on my home territory and in my homelands is about that connection to place, to history, and to the future, and really understanding that my work to do is rooted in this place and point in time, but is part of that continuum.
Now, again, for our international listeners, Canada has this reputation of being, and I have to use air quotes, right, multicultural. So do you want to break down why your grandmother would be told that she couldn't be a nurse?
So in the mid 50s, when my grandma moved to Winnipeg, and then she was a young mom, she did have 8 kids altogether, raised some cousins too, was looking for extra income to support the family, was working essentially as a healthcare aide at a place called Central Park Lodge in Winnipeg, so a personal care home. And when she saw some of her peers getting tapped on the shoulder to go into nursing program, wanted to do the same thing. And she was explicitly told Indians can't be nurses. So had nothing to do with her capacity, with her intelligence, with her kindness, with her compassion, with her demonstrated service for the people there, that based explicitly on racism, she was told she couldn't be a nurse.
So then it's very powerful then, as you mentioned, that now you're this phenomenal physician leader as a Cree Anishinaabe woman. Actually, so let's kind of get into healthcare, because your grandmother wanted to be in healthcare and then now you are a physician. So thinking about what it is like, let's even say present day, not even back then, for a patient in healthcare being Indigenous, what is that experience like, even though now we do have Indigenous physicians like yourself and a full Canadian Indigenous Physicians Association, but for your average Indigenous patient who enters healthcare, what can that experience be like?
Yeah, such a great question. And, when I want to recognize there is a big, huge range of experiences, and some of them are positive. A lot of the evidence shows that there are significant gaps in healthcare quality. And then all too often, we have the catastrophic moments, the episodes like the terribly, blatantly racist healthcare that Joyce Echaquan received very recently at the end of September in Quebec. And one of my reflections on that, so I had to go to the emergency room this week with one of my daughters who fell and hurt her arm. And, even for me as an Indigenous physician, that makes me nervous. I get worried about how we're going to get treated there. Are we going to get equitable, high quality health care? It's her third broken bone. She's 9 years old, and actually the second within the past few months. I get worried what they're going to think about me as a mother. Is CFS going to get called? That day I happened to be wearing a t-shirt that said land back on it and these giant hoop earrings that said decolonize, because I'd been thinking about what was going on out on the East Coast and Mi'kmaq treaty rights and fishing and harvesting rights. And I thought, how is my attire going to impact the healthcare that we receive? And so I think that's the biggest thing that I would say is too many Indigenous people have to have those considerations going into healthcare, that it's not we don't walk in with the expectation that it's going to be a good experience. That too many people I know weigh what is the risk of me entering healthcare versus me avoiding healthcare, like which is going to be more risky to my health right now when deciding whether to get healthcare or not. And I think that is really the major reflection of systemic racism that we see in healthcare, when people have to weigh the risk of showing up for healthcare with the risk of avoiding healthcare.
I think that is exactly a point that a lot of middle-class white Canadians don't have to think about when they go for care, is really engaging in that calculation that you're describing, about that painful calculation of balancing risks and harms of showing up to a place where you should be able to get quality, dignified care. And I know you've given us kind of the example of, just recently with your daughter, but I know that you have spoken publicly about another episode that you personally had with your own dad presenting to the emergency department, presenting without you right there as his advocate. Would you be able to kind of tell our audience about that experience?
Yeah, and one thing that I would say, and this is related to what I had talked about earlier, is even though, this episode happened years ago now, 2003, that it still impacts me, that it's still part of my healing journey as well. So while it's been the fuel for a lot of the work that I've done, which is positive, that it was still hurtful and harmful and has those impacts, because I also don't want to be seen as minimizing the damage that gets done to our health and well-being and our dignity when these episodes occur. So what happened with my dad, I was an internal medicine resident at the time in my second year, taking care of people with heart attacks and heart failure and rhythm problems, and I was post-call. So I was at home. And it was almost 10 o'clock at night. I was getting ready to go to bed when my mom called and said that my dad had collapsed and was in the emergency room. And so I immediately went there. There was enough things said that I knew to be concerned. And because it was the hospital that I was working at, I didn't have to go through the waiting room or check in at the desk. I just went around and entered the emergency room directly. And couldn't find my dad in the stretcher bay area, and noticed that there was a lot of activity in the resuscitation room, which made me very concerned, obviously. And then one of my colleagues, one of my peers who was on call, turned around and saw me, and the way that his face dropped, I could tell that he had just put it together and realized that was a family member of mine. So he came over to talk to me, and I said, "Is that my dad?" And he said, "Yes." So I asked what had happened, and my dad had had multiple cardiac arrests at that point. So he took himself to the emergency room and then had a cardiac arrest in front of the triage desk, had been resuscitated and taken to the resus room. So I, took a deep breath and headed towards the resuscitation room, and I was expecting to see him with a breathing tube in, hooked up to the monitors, but I was expecting him to be sedated, lying down there with people working around him. And I would say there were at least 10 people in that room, like 10 healthcare providers in that room, and at least 3 of them were actually trying to force my dad to lie down. So he was not sedated. And I walked up to him, and I said, "It's okay, Dad. I'm here now." But he was in shock. His eyes were glazed over, didn't show any sign that he recognized who I was or really was aware of anything that was going on at all. And so I looked at the emergency room physician and I said, "Why is he not sedated?" Which would be standard of care for sure in that situation. And the emergency room physician looked at me and said, we didn't know what he was on, clearly implying that they thought he was intoxicated with something. And, you know, for listeners who don't have a medical background, I would just say at that point, when he was already intubated, in shock, critically ill, there's nothing he could be intoxicated with that would be a contraindication to sedation at that point in time. And so I looked at the emergency room physician and I said, he's not on anything, sedate him now. And so they did. And once he was sedated, I again said to the emergency room physician, what did his EKG show? Because again, cardiac arrest in that situation is a heart attack until proven otherwise. And he said, we didn't do an EKG. And I said, why not? And they said, because he was fighting too hard. And so within minutes had established that this incorrect racist stereotype was compromising my father's medical care. And so I said, you had better call EKG now. And they called an EKG 25 to the recess room. And, you know, they came in, they did the EKG. And I don't know if it was because it was apparent I was the person in charge in the room at that point, or because they just assumed I was on call as a CCU resident, but they actually handed the EKG to me, not to the attending physician. And it was an obvious massive heart attack. So I turned the EKG around so the physician could see, and I said, who is going to call the cath lab? And there was just silence in the room. So I looked at my colleague who I knew was on call, and I said, can you call Dr. Kishore, who was the interventional cardiologist on call? He made the phone call, and of course, Dr. Kishore said he would get the team in as soon as possible. And then I looked at the doctor, and I knew my family would be arriving soon. And I said, when my family gets here, you put them in a room and I will talk to them. Because they'd already demonstrated they weren't safely taking care of my father. I had no confidence that they would be able to talk to my mom, my grandparents, my siblings, my aunts and my uncles in a safe way. So I stayed with my dad until he was transferred to the cath lab. As my family arrived, I would go and talk to them, and some of them were allowed to come in and, you know, see my dad, who was critically ill. And then the cardiologist came, assessed my dad, asked if I would come to the cath lab with them, so went right up to the cath lab as well. Dr. Kishore did an amazing job. My dad had to be resuscitated in the cath lab again. Needed a bypass surgery, but was too unstable for that to really even be considered. So they put in the stent and some other, you know, supportive critical care that he needed. And he went to the ICU and he was there sedated for 12 days. So for 12 days, we didn't really know kind of how he was going to be if and when he woke up. And it was a devastating time. And in those moments, you know, I did not have an opportunity to kind of really process anything. All I could think of was, your dad needs you right now. Like, yes. You can be the daughter or you can be the doctor, but you can't be both. And what he needs you right now is be the doctor, and then we'll fix the rest of this after. So.
And I want to thank you for sharing that story, because it's clearly a deeply traumatic story of, yes, you as the daughter having to kind of divorce yourself from your key role, which is to be the daughter, and to come in and be the doctor in a situation where actually you weren't a full independent practicing doctor. Like, so for those who don't know what a resident is, it means that you were still in training. And it's not like in a big city, like you knew all of those, you knew some of those people or were in that working environment with them as a trainee, and now had to step in and take command and control of your dad's care.
Mm-hmm.
And where they thought he might be intoxicated, it was based on stereotypes, but also, as your point, and he wasn't intoxicated, but
Mm-hmm.
your point is, even if he was, that wasn't a indication to sedating him in the first place. And so I think on the one hand, like, first of all, just thank you for sharing that, because I know how, actually I know from firsthand account of my own journey and issues with my own father's health, where I've had to step in multiple times because of assumptions that had been made. And I also know what it is to dress up extra in the, to be in the ICU so that you're not stereotyped and can, advocate. But I'm really interested in you talking about what you said, what you just said about your processing and your journey of healing from that. Because earlier you talked about how important it is for us to understand how in these processes of healing, it really has an impact. I also want to flag that when we are asked to talk about our experiences of trauma, that also has its impact. And so I didn't ask you to talk about it just for the sake of voyeurism, which I think happens a lot. And I think for all of us who are BIPOC people, when we're asked to give our stories, we need to be mindful of that. Like, to what purpose is it serving? And is it going to further traumatize us? But in this case, we are centering the margins, and we're going to talk about we're going to focus actually on the process of healing, so that others can learn from that process of healing. And so can you talk about, and you mentioned you're still on your journey, so I appreciate, again, you sharing, but can you talk about some of the steps that you took? And it doesn't have to be in perfect chronological order, but how did you engage and embark on that process of not being stuck and starting to overcome the trauma from that?
Yeah, so, I think there were a lot of steps along the way. One thing was I left Winnipeg for a period of time. The first day I was back on call in St. Boniface, one of the nurses from the emergency room who had been on that night came to me and kind of wanted to recount their experience of that night. Because the other thing is, everyone now in the system knows this has happened, right? For sure, people were talking about it, my role in it, what was going on with my dad. Like, we were in the hospital for a month.
Right.
Everybody knew what the situation was. And the first time that I was back on call, and in the emergency room, one of the nurses came over, and in recounting their experience of the night, and the person was white, in recounting their experience of the night, provided more traumatic information. And that, combined with some of the stuff that was happening in my program, was just like, I can't do this. Like, I can't actually be in this physical space. One, because I've had no support, like no one had reached out or asked what kind of supports I would need for my mental health or anything around that at that time. But then to be with people who had been part of that night and hadn't intervened, or who wanted to debrief the night with me, I just couldn't carry that weight. So I had to leave for a while, and that was part of it. And I think that's an important part. It's not necessarily that any other place is better or less racist, but sometimes you need to not be where you were traumatized specifically in order for you to be able to deal with it, right? So I did leave for a while. And then another thing that happened, kind of within a year, was I got asked to start taking on some leadership roles nationally in Indigenous health. And that was an avenue where I thought, okay, I can start to make a difference here. And it was specifically related around how we train medical students in Indigenous health. So there was a really great avenue. One of the cautions I would have around this that I'm much better at now, but was also a learning process, is any positive coping mechanism, any strength, if it's overexpressed, can start to be damaging. So I kind of went too far with it and started doing, in addition to my residency training, this national level work and research and like really overachieving, like even for an overachiever, which led to also experiencing some burnout and depression. throughout the later part of my residency. And so I just wanted to raise that because I know for a fact that's not a unique experience to me. And I've talked to too many other Indigenous folks and certainly some Black folks as well who've had that experience where when your response to the trauma is to work in every area that you can to try to prevent it from happening to somebody else, but that really also starts to damage you and wear you down. So that happened. Went to Hopkins, as you mentioned, because I wanted that broader system level view and some good high level analysis, because it wasn't the one individual physician, it was everyone else in the room. And it was the fact that they all thought that was okay without potential consequences that was the big problem to me. And so wanting to be able to work at the systems level.
So that was the master's in public health.
Yeah, that's why I went to the master's of public health. I'm like, if we want to pursue systems change, then we need systems analysis and systems training. So that was helpful for me. And then when I came back to Winnipeg to start practicing with some more tools and joined faculty in 2007, I did also begin investing in a coach, life and leadership coach, and started creating space for me to do some of the actual work that I needed to do personally to be able to do this work, understand the motivations and the things, even the traumatic things that have happened, but be able to have more boundaries and balance around that so I could enjoy my life too at the same time as doing this work and be healthier. So those were some of the kind of first few years that set up the foundation for where I am now.
And I think that is phenomenal, like really being able to, that self-awareness that you had to take some time to yourself and not be in that environment, but then turning pain to purpose and trying to find ways that you're engaging in system change. Although, as you said, one has to be mindful not to go too far in trying to overachieve or overcompensate, and then deciding to do the Masters of Public Health for systems change, right? And then the coach. Now, with the Masters in Public Health, like you were in the United States, and at that time you were learning, correct me if I'm wrong, about concepts like critical race theory or things around how racism impacts health and impacts other things. As an Indigenous woman from Canada or a physician, being in the United States and learning about race there, were there any observations that you think would be helpful to this audience about what you experienced or saw at Hopkins?
So, going south of the border to go to Hopkins was interesting to me in that there's this mythology that starts at the border, where north of the border might recognize anti-Indigenous racism, but there's a lot of denial around anti-Black racism and Canada's role in slavery. Whereas south of the border, the invisibility is more around Indigenous peoples, and the role of slavery and anti-Black racism more recognized, right? So there's this mythical border difference, when in reality, I would say the experiences of Black and Indigenous people are borderless in North America. The other aspect of this that was kind of fascinating to me was that my indigeneity brought me some degree of invisibility there. So I was not experiencing targeted anti-Indigenous racism. I was also, for the first time in my life, amongst the most privileged in the setting, because I was getting paid as a medical resident still. I was also on a full scholarship at Hopkins. So I did not pay tuition or anything, and I had a living stipend. There are very few Black students in Hopkins. And most of the Black employees were members of security or physical plant, not a lot of Black professors either. And through my networks, had learned that the local Black communities refer to Hopkins as the plantation. So it was the first time that I kind of recognized my personal implication and benefit from anti-Black racism and how that was playing out there. And some really fascinating stuff around the local Black communities that Hopkins is situated in and their relationships to it, compared to the kind of missionary international health approach in Africa.
Right.
And so understanding all of these different dynamics around anti-Black, anti-Indigenous racism, whiteness, and academia became foundation for my critical understandings of health systems and medical education.
So I think that's like extremely powerful and speaks to the benefit of where we can and have the privilege to go and be immersed in a different environment, because you came back and it informed your lens of, understanding anti-Indigenous racism, anti-Black racism in Canada and internationally. Now, one of the things that I was also hoping to speak to you about on your journey was understanding the concept of radical self-care. And usually at the end, I ask my guests about what brings them joy. And I think we can actually combine the two, because there's no way we can talk about radical self-care and not talk about joy. So in this last few minutes, can you talk about what is radical self-care? And then perhaps tell us a little bit about what brings you joy.
So to me, and this was something that really, I would say, has been more of a focus in the last 7 or 8 years. Radical self-care is getting to the point where I recognize that part of my full humanity means that I have a full right to also enjoy my life. That I'm not actually obligated, nor does it serve anyone, for me to sacrifice myself on the altar of anti-racist change. That my piece of the work is limited to my piece of the work. And that is less than all of the work that needs to be done, and that's okay. That there's no way for me to do other people's work and be well and happy myself, but also I'm getting in their way of them being able to do their work too.
That's an interesting point, yeah.
Yeah. And so for me, and this was a lot of work that I had done with my coach especially, was learning to understand what my work is, to understand that I did not sign up for suffering in this world, and that I am equally entitled to health and happiness. And then a couple years ago, when I became an executive coach myself, and I looked into some of the positive psychology stuff as well, that actually we are going to be more effective in the revolution when we are healthy, happy, and well ourselves, and so that actually taking care of ourselves is literally part of the revolution, as Audre Lorde said, because we're better at it. We're better at the revolution when we are healthy and happy, and we're working from that place.
That is phenomenal. Do you want to give a little tip about what brings you joy in particular on that radical journey of self-care?
Yes, so things that bring me joy. I do love to work out and lift heavy weights, I have to be honest. So I am a bit of a gym rat. Love that. I love the post-workout endorphins, those feel-good chemicals for sure. My kids, of course, bring me a lot of joy. And then one of my absolute favorite things is connecting with other Black and Indigenous folks and laughing, having these deep conversations, and just that connection and solidarity. So those are definitely things that bring me joy.
Well, girl, I hope this brought you joy, because it definitely brought me joy. So on that note, I would like to thank you for being on our podcast, Race, Health, and Happiness. Thank you, Marcia.
You're welcome. Thanks so much for having me.
The Race, Health, and Happiness podcast was created by Dr. Onye Norum, and she's our host. The show is produced, edited, and engineered by yours truly, Dr. Carl Cabasel. Our technical producer is Obadiah George. Awit Siam is our research and resource manager, and Sindhu Senthil Mohan is our medical research consultant. Promotions coordinator is Jordan Gibson, and social media coordinator is Latoya Powell. Javiera Gutierrez Duran is our logistics coordinator, and JL Joseph is our production intern. The RHH theme song, this beautiful music you're listening to right now, it's composed and performed by Gold Keys. That's Gold Keys, all one word, ending with a Z. And graphic design for the podcast is handled by Veronica Michelle. Do you have questions, feedback, ideas to share? We'd love to hear from you. You can connect with us on Instagram and Twitter at RaceHealth&Happy. And check out the show notes for the research that was referenced in this episode, as well as other bonus material. Our website is RaceHealth&Happiness.com. Thank you for listening to Race, Health, and Happiness, and please subscribe to us anywhere you get your favorite podcasts. I'm Dr. Carl Cabasel, and we'll talk with you soon.